Alright, let's start the PowerPoint and the lecture for Lesson Plan 2. This is covering chapters 4, 5, and 6. And in this lesson plan, you'll see the readings for chapter 4, chapter 5, and chapter 6, and they are abbreviated readings, so you need to make sure you follow those. Recommend that you do your review readings on those chapters as well that I've posted so you can keep up, get that basic knowledge that you need. In this chapter, or in this lecture, we want to talk about some theories and therapists that we deal with, some social, cultural awareness, as well as spiritual awareness. So let's just get started. Psychiatric therapies. If you look in your book and you do that review reading that I talked about, the whole first part of chapter 4 in the Potter book is a review of therapists that you should have got in nursing, in Psych 101 or behavioral or developmental side. So you need to go back and review those because those are the basis for what we do in mental health, but I'm not going to dig back into those. You do need to kind of refamiliarize yourself with who and what they are, like Paplow's theory of interpersonal relationship and kind of what that is. Newman's systems model, and what change theory is, what cognitive theory is, what behavioral theory is. You need to review those and just get an idea of the concept, because that's what we want to build on. Psychiatric therapies are provided by licensed therapists. It can either be advanced nurse practitioners, mental health nurses that have advanced training, mental health counselors, licensed clinical social workers as well. There's licensed addictive specialists, psychologists, and psychiatrists. So there's a combination of people who can provide a variety and different modalities with these therapies. Each therapist tends to work at a specific location or specific population. Some works on children's, adolescents, some only does adults, some only does geriatrics. So it just kind of depends on the population that they choose to work with. And most therapists normally stick to that general population. Certifications are required or specific educational programs combining these theories and evidence-based practice to help these mental health clinicians provide the care that they need. Psychological therapies include what we call talk therapies. And so when you hear me talk about psychological therapies, that's talk therapies, that's sitting down, talking with people, interacting with people. When you hear biomedical therapies, that's normally your pharmacology, as well as there's brain stimulation, electroconvulsive therapy, and there is some psychosurgery that we will dive into later. So let's look at psychological therapies. Again, I said they were talk therapists. These are your typical what you think of when you go into the therapist's room and you sit down and you start talking, interacting with someone on the other side. You're talking out your issues. Remember we talked earlier in the earlier lectures about listening and how important that was and how important it was to talk and communicate with someone. This is the reason why we have those talk therapists. The goal in these talk therapies or psychological therapies is assessing the patient's mental illness and engaging in a therapy mode that will decrease symptoms and increase function. We want to cure them. That's our goal. We want to try to get to the most attainable life function that there is. Some providers will adhere to more than one theoretical approach that we're going to talk about here in just a second, while some providers just adhere to one. Some may do cognitive therapy, some may do behavioral therapy, some may do cognitive behavioral therapy. There's a combination, so it just kind of depends, and it depends on what works best for the patient. Some therapies are briefer than others. Sorry about the dog barking, guys. Anyways, some therapists adhere to different approaches. We talked about that just a second ago. And some therapies are briefer than others. You have some therapies that last long term, 6 months, a year, and then you have some therapies that will last maybe just 2 or 3 visits, or just even 1 visit. So there is a variety of times, a variety of approaches, a variety of things that we see in the mental health aspect. Psychological or talk therapy is also based on some major theories, and this is why I want you to go back and review those theorists in the front part of this chapter. Psychological therapy is based on their psychoanalytical therapy, excuse me. That's the therapy that lasts a long time. Most insurances do not pay for that anymore. You know, most insurance coverages may have, 6 visits, 12 visits at most for therapy, but that is still out there if you want to private pay for it. There is psychosocial theorists, humanistic theorists, interpersonal theorists, behavioral and cognitive theorists. So you need to go back and review those to make sure that you understand the different types of theories that's out there that our care is based on. The first one we want to talk about is behavioral theorists. Behavioral theory is on page 79 in your book. It's indicated when there's a maladaptive behavior of the patient. And remember, we talked about that adaptive, maladaptive behavior the other day, last Wednesday, I believe. If you have a stressor, if you have an event, if you have an anxiety, and you cope with it, and you deal with it, and you come out on the other end of that event, then you have adaptively dealt with the problem. If you can't cope with it, if you're drinking, if you're doing drugs, if you're having reckless behavior, if you're acting out, creating some sort of issue with your daily life, remember, problems, these become issues or diseases when they affect our daily function, then it's a maladaptive behavior, and that's when therapy is needed. So behavioral therapists, again, indicator therapy, again, indicated when there's a maladaptive behavior with the patient. This is more successful when the patient is able to identify behaviors or thoughts that are causing distress. If you go back and read what behavioral therapy is, or what the behavioral theory is, it basically says that there is a behavior causing the problem. And if we change that behavior, then we fix the problem. And in order to be able to identify, to fix the problem and to say there's a behavioral issue, then we have to be able to identify the behavior. So hence, this is more successful when the patient identifies the behaviors or the thoughts that's causing the distress. That way, if they identify them, then they can work on them. Both patient and therapist collaborate to identify stressors and strategies. Remember, in mental health, you have to work together. It's a collaborative event with our patient and with us providing care. And reinforcement strategies are very useful. You always have to reinforce, whether you're reinforcing good behavior, reinforcing positive outcomes, you want that reinforcement. Children are very receptive to behavioral therapy. It's used across the lifespan. Stickers, charts, responsibilities can be checked off. It's a good way to show you that you're making progress. Some examples of behavioral therapy you'll see on the next slide. Behavioral techniques for systematic desensitization. That basically is the reduction of an individual's negative behavior or exposure to a feared object by situationally pairing with an activity designed to offset the resulting anxiety. For example, a patient fears public speaking, learning stress management and breathing may be helpful. The individual might practice this breathing technique while thinking about an event, prior to going to the event, and during the event with the anxiety. Then there's aversion therapy. It involves exposing the individual to a painful or obnoxious stimuli that is paired with something the individual desires. Classic example of this is the anti-abuse drug. And we'll learn with that as we go through the substance abuse chapter. But however, anti-abuse is a drug that an alcoholic that can take, and then as soon as that alcoholic takes a drink, that anti-abuse makes them extremely nauseous, very sick, almost deathly ill. So, they know aversion. They know if I take this pill and I drink, I'm going to get sick. So that prevents them from drinking. Again, changing that behavior. Then there's modeling. Modeling is particularly useful with phobias. Modeling you offer the patient the opportunity to observe someone doing or handling the situation in an appropriate way, modeling that behavior. Then there's extinction, withdrawal, or reinforcement of the negative behavior. For example, the patient stops addressing temper tantrums. You're just interpreting behavior instead of ignoring them. Then there's punishment, the withdrawal, positive reinforcement, or the application of negative reinforcement in response to the negative behavior. And then there's token economies. A token economy is used a lot with children, and it's used a lot also in mental health institutions. It's used in hazard. They use it as well. So they get tokens for good behavior, and then those tokens can be spent on numerous things, whether if it's inpatient, hazard has a little store over there that they can take those tokens in and spend. Or you can give the children tokens to win prizes or rewards. Changing that behavior. So you give them something that they want in order or a reward for changing the negative behavior. Then there's cognitive therapy. Okay, again, go back and read if you're not sure what cognitive therapy is. It was developed by Aaron Beck. It encourages individuals to rethink or reframe negative, pessimistic thoughts. This is the think positive instead of negative type thought or correction. It does not address issues from the patient's past. That's the thing with cognitive therapy, but it looks at the present. How can we change things going forward? How can we change our thought process going from this point on, looking at the present? It examines cognitive distortions. It looks at things that negative thought patterns, illogical thought patterns. It looks at the cognitive distorted thought and tries to fix that through rethinking or reframing those distortions. Patients are encouraged to challenge beliefs against evidence. They're encouraged to look at what they're thinking and look at the evidence and see how, this evidence proves that this thought process is not correct. That's basically what cognitive therapy is. Okay, then we combine them. We also have the cognitive behavioral therapy. This is one of the most effective psychotherapies that there are because we're looking at the thoughts as well as the behaviors. It helps the patient examine and reframe negative thinking patterns while replacing them with constructive behaviors. It generally involves homework, again, very short duration, and it's effective with patients with psychosis. Okay, then we're going to move into biomedical therapy. And I remember me talking about there is the psychological or the psychosocial therapists. Those include the talk therapies. Remember I talked about biomedical therapies, including the pharmacological aspects as well as brain stimulation. I'm not going to talk about drugs at this point. We'll talk about drugs as we deal with each behavior. So we're going to look at some of the other biomedical therapies out there. Transcranial magnetic stimulation. This is a non-invasive therapy. It involves placing a large coil, and I've got coil there, it's supposed to be coil, sorry about that guys, that's coil, on the left prefrontal cortex near the forehead. An electromagnet causes electrical currents to stimulate the nerve cells that affect mood and depression. This normally with severe depression has benefited from this treatment. Nurses help reassure the patient when this is going on. We don't actually do the procedure. It's a non-invasive procedure. It's done without anesthetic, surgery, or implantation. There's normally no pain involved, so we're just there for reassurance, asking questions, being there to help that patient as they need it. Treatments normally last for about 40 minutes, and 5 treatments are normally given up to a 6-week period with biomedical therapy. There's electroconvulsant therapy. This is what everybody thinks of as shock therapy. It's different than the magnetic stimulation in that we're just stimulating the nerves. In the electroconvulsant therapy, we are actually shocking them into some sort of grand mal seizure. It's used for treatment for severe depression, suicidal, refusal to eat, any point to where we can't get that person to turn around by any other means out there. No, you're not responding to any treatment for anything, and this is kind of the treatment of last resort as far as that goes. I'll have a video up on Whiteboard so you can actually watch one of these happening and you can kind of see the role of everybody involved. Electrodes are placed on the right side of the head and on the top of the head, or bilaterally sometimes, depending on what that patient's need. A muscle relaxant or some sort of anesthetic is given to kind of put the patient in a conscious sedation. Treatments range from 4 to 20, but averages normally about 6 to 12. Patients need special considerations because for diabetics, there's no eating or drinking after midnight, so you have to watch that. Pregnant women, it affects fetal heart rate. Those with cardiac or hypertensive issues, blood pressure, those are things, that's another population that has to be monitored. And those with glaucoma because it increases the pressure in the retina. Nursing care during, before, and after CT. ECT includes providing education and support. You will hear that throughout this next 16, 15 weeks, however many we have left. A big part of our role in mental health is education and support. Assuring that the patient has no pain during the ECT, and instructing the person who smokes not to smoke the morning of the procedure, because smoking can interfere with the treatment. And inform the patient that the electrodes will be placed on the head, so there could be some shading of the hair that's involved. We will also place electrodes on the heart. There could be some short-term memory loss that needs to be educated to the patient. They can have some confusion short-term, as well as extreme fatigue are common after the treatment. The mood normally tends to lift about 2 or 4 treatments. You know, this is not a one treatment, one shot, one fix. They have to have, again, if you remember, I said 6 to 12 is average, and we normally see an increase in mood after about the 4th or 5th treatment. They cannot drive after the treatment, so they have to have someone there to drive them home. Performing assessments, we have assessments that we have to do. Again, I talked about those special populations, so you need to be able to address those. Removing of contact lens, dentures, going to the bathroom. Think of all your pre-surgical type things that you do. You do those with these as well. They can have an IV to do the muscle relaxant as well as there for post-procedure support if needed. During the procedure, again, this is not something that we actually do. The psychiatrist actually does, or special trained individual actually does the electroconvulsive therapy. But we're there to monitor the blood pressure, the oxygen administration, all their vital signs, making sure the patient remains stable through the procedure. After the procedure, we are again monitoring those vital signs, making sure that person remains stable, waiting for them to come back out of their conscious sedation, and of course discharge instructions and all those good things after that point. Here's a list for you to kind of go by. Again, most of the instructions, I said, providing education, performing pre-assessments, monitoring the procedure, and observing and interpreting post-treatment patient responses. Psychosurgery. Again, don't see this done very much anymore, but I just kind of wanted to touch base, let you know that it is out there if needed. It severs or disables a part of the brain, and basically with that, we're talking about the limbic system. And again, you need to go back and review your H&P if you're not quite 100% sure what the limbic system does. The psychosurgery involves the severing or disabling that part of the brain. The first psychosurgery was performed in 1891, if you can look in your book, and it basically was done on people with severe aggression and dementia. The results were diverse, not necessarily evidence-based practice. The first prefrontal lobotomy was performed in 1937, and again, that's considered a psychosurgery. Again, those are not done this day and age anymore. Psychosurgery is reserved for patients with refractory psychiatric illnesses who experiences no period of remission. So these are for people who are long-term issues. However, these procedures occur only in a small number of medical facilities, and they are very, very restricted. Again, this is not something that you will see on an average everyday basis, but you just need to know what's out there. The two that are done today, that you see there on the third bullet point, both procedures involve using heat or gamma radiation to sever nerve bundles. That's what those are doing, that are implicated in obsessions and compulsions. And nursing care is based on hospital protocol. Again, I don't want you to dive much into this, just to know that it is out there and it can happen, but it is very, very, very reserved. So let's move on into culture, providing culturally competent care in the psychiatric nurse. Again, the first part of Chapter 5 just deals with culture in general. You should have got that in 101, not going to dive back into that. But if you do need to review that, please feel free. Provider and culture competent care in psychiatric nursing. Different cultures look at mental health different ways. It's very stereotypical, and we need to understand that. Your book has a very good table on page 93, table 5.3, that discusses the different cultural groups, some of the physiological problems or the physical problems, as well as the mental health problems associated with those groups. So you can kind of look and see that, yeah, there is some cultural themes that go along with the different mental health issues. And just kind of familiarize yourself with that. You don't need to word it word for word, but just understand that African Americans can have, brain fog, or they can have falling out. Understand that the Indians can have Wendigo. The Hispanics have theirs as well. So make sure you just kind of read that and understand what's going on. People from Asian cultures often misdiagnosed with physical problems over mental health problems. There is culturally bound symptoms, and that's what I was talking about on that table. They're listed in the DSM-5. And I will bring one of them to class with me the next class that we have. That way you can actually see what a DSM-5 looks like. Disorders among different cultural groups, again, and they may invoke that stereotypical view. You may, think, well, all African Americans have this brain fog, physical and mental exhaustion, difficulty concentrating, memory loss, inability to sleep, and appetite disturbance. Well, we have to make sure that we can't stereotypical. Just because we're black, we can't say this is what's going on. We do have to look at that medical side versus the mental side. Again, here's that chart. I put it in here for you to review, as well as it also in your book. So make sure that you do read that. Providing culturally competent care in psychiatric nursing. That's the key thing. We have to understand how to provide this culturally competent care. How am I going to address these issues while providing that culturally competent care? If you remember back to 101, that's a very important aspect that we have. And in order to provide culturally competent care, we have to learn about our own culture. We have to understand our own culture and our own heritage, and respect that when we're talking to other patients. Providing culturally competent care for patients with mental health disorders involves knowing our culture as well as knowing their culture, and not wanting to invoke our culture on theirs, and being able to understand and adapt or appreciate their culture. It involves allowing patients to provide information about their culture. We want them to make sure they tell us, what's going on in your culture. Listen intently to their views of health and illness. How do they look on it? What would help that patient heal? Or who would that patient want to help him or her? Those are some questions that we have to ask ourselves in order to provide culturally competent care. And that goes with mental health as well as the medical side. And I know you got that in 101, so make sure you review, how we want to provide that culturally competent care. Again, dealing with a Muslim and their death rights. You know, there's certain things that they do when a person passes away, and we have to okay with that. You know, we have to understand, you know, that our culture and our views on things might be, well, you know, you just bat the patient, put them in a body bag, and send them to the morgue. But when you're dealing with the Muslim culture, then that's not the way they do things. So you have to understand that and be able to look at those views, listen to what's going on, so that patient feels in tune with you. We have to involve the family members in that. That's a good way to understand the culture. You know, ask questions. And, you know, it's always good to learn. It's something that you can apply later on in your career. Personal knowledge of the client's powerful as a clinician's knowledge. Personal knowledge of client as powerful as the clinician's knowledge. You know, what we know from that person and what that person tells us is just as powerful as what that clinician is going to tell us. Acknowledge a disparity in mental health services and seek to distribute care in a more equitable manner. There is disparities in mental health as far as culture goes. We try, you know, with everything, we try to loop everybody or put everybody in one big group. You know, here's this, here's that, here's this. We can't do that. We have to be able to understand that there's a disparity, and we have to distribute that care in a more equal, more adaptable manner. And we can't stereotype. Again, that's what this people of color much more often diagnosed with psychiatric conditions. We have to understand that with that, we don't want to stereotype as far as that goes. Because mental health disorders are different among whites, different among blacks, different among Asians, and we saw that in that chart. So we have to understand that and be able to provide that care. Again, I said the DSM-5 includes culturally bound syndromes. Again, those are addressed in the DSM-5. And they are found among different cultural groups, and we have to consider that with caution because we don't want that to stereotype. Just because it's listed here doesn't necessarily mean that all blacks are going to be this way, all Asians are going to be this way. Vulnerable and at-risk populations. Let's talk about that just for a second. Working with these populations require innovative, culturally sensitive means for reaching out. So these are populations that are vulnerable and are at risk. So these are some of the things that we can do. Migrant farm workers. Okay, culturally, you know, most of our migrant farm workers, again, in this area, we don't see that, but if we move to different areas, if you branch out from Eastern Kentucky, you will see migrant farm workers. They're normally of the Hispanic or Latino type things, or type cultures, excuse me. And, you know, one way that we can work or provide care for those is a mobile clinic, because they're not going to come in and seek assistance. You know, so that's one way. Sex education classes for urban schools and pregnant teens. That's another way that we can reach out and provide culturally sensitive, meaningful care to populations at risk. National Depression Screening Day. They're out there for the Guard, the veterans. You know, we hear all the time about vets coming back and having issues with depression. Again, these are some of the ways that we can help these culturally at-risk people deal with these problems of behavioral mental health issues. What makes someone vulnerable? It could be as easy as their race or their ethnicity, their ability status, their developmental status, their sex, their age, their gender, sex orientation, or just the geography or their socio-economical status. Any of that can make a person vulnerable. Social determinants of health are those circumstances shaped by economy, where you live, where you grow, where you work. Another thing that can make a person vulnerable at risk, again, is poverty, unemployment, low educational opportunities, ethnicity, stigma about mental health. These are factors that contribute to that vulnerability, and we have to find out-of-the-box thinking ways to deal with our patients to get them the care that they need. With the vulnerable and at-risk population, a lot of problems that come along with it, not only is the cultural side that we don't want to stereotype, but just mental health and a stigma or a view that the overall population or overall culture or overall United States have with mental health. If you ask anybody on the street right now if they would go see a psychiatrist or if they would go see a psychologist, and I talked a little bit about this earlier, they wouldn't go. They would say, "Are you kidding? No, I'm not crazy, or I don't need to go see a psychiatrist, or, I don't have anything wrong with me." There's a shame and humiliation with mental health, something to hide. And we have to deal with that. We have to be very open with our mental health. Enacted stigma is what it's called. Actual discrimination or mistreatment related to having a stigmatized condition. So when you discriminate, if you mistreat anyone because they have a mental illness, if that's an enacted stigma. You're actually acting on that stigma or that stereotype that's been given. A lot of these come from passed down from year to year, generation to generation. The media and society are really bad with picturing what a crazy person should look like, or what someone with mental health should look like. Someone with depression should act like this. Someone with Munchausen syndrome should act like this. Someone with a narcissistic personality disorder should act like this. And that's not always the case. So we have to understand that and not apply those stigmas. You can have an internalized stigma. Individual accepts the stigma as characteristics of self that contributes to self-hatred. So you're internalizing that stigma. You're accepting the stigma as a characteristic of that person, and that's not true. So when you look at a black person and you say, "Oh, I bet he's a bank robber," or "Oh, I bet he's a gang member," you're accepting that characteristic and internalizing that stigma. And that's another thing that we have to avoid. As people, that happens every day. As healthcare professionals, it happens, but we have to learn to deal with it. We can't have that guilt by association. We can't have that understanding that, oh my gosh, this is the way it is. Mental health is often not taken seriously in primary care or hospitalizations for medical problems, but we have to understand that the mentally ill get sick and those have to be treated. If a schizophrenic goes into the hospital, we have to treat their medical issues as well as the schizophrenia, or we're going to end up with issues arising that we don't need to deal with. So we have to understand that, mental health is a serious issue, and it is getting better. We are addressing mental health problems better than we were 10 years ago, better than we were 20 years ago, and most certainly better than we were 50 years ago. So we are seeing an increase, but through education and understanding of these issues, that's where we're going to see the improvement come along. If we don't, it contributes to poor health outcomes, both mentally and medically. So we have to make sure we address those. And we don't want the diagnosis to be distorted by culture. Remember, culturally bound syndromes, we don't want those to become, because black people can have this brain fog, but everybody has a brain fog. So we have to understand, don't loop those together. Caring for patients with different cultures, there's there's assessment tools, there's just knowledge that you can learn yourself, there's the DSM-5 measures, there's the WHO Disability Assessment Schedule, which is the World Health Organization. There's culturally formative interviews that you can find out there that explore the 4 domains: cultural definition of the problem, cultural perception of the problem, content and support. So, there's things out there that we can do to help us provide care for culturally competent or culturally different people. Again, not everybody is the same as we are, so we have to understand that and be able to adapt and change with it. Culturally formative interview explores the 4 domains: cultural factors affecting the self-coping and past help-seeking, cultural factors affecting current help-seeking things. So there's those interviews that we can use, and those are talked about on page 94. There's a little box 5.1 that says culturally formulation interviews, so you might want to read that. Early use establishes the context of a relationship and demonstrates the nurse's commitment to culturally relevant care. And that's the key thing. We want to look, we want our patient to feel comfortable in saying, this person cares about me. And the really good way to say this person cares about me is addressing those cultural issues, addressing those specific issues that the patients have. Nurses must not only read about, but experience different cultures. It's good to go out there and see what the different cultures are. And, just don't think cultures is going from here to Africa or from here to Asia. Think of different cultures as going from here to New York, here to Florida, here to the Midwest. Their cultures are different than ours. So you need to explore those. Don't be afraid to travel. Don't be afraid to read. Don't be afraid to learn, because it's only going to help you provide care, not only medically, but also mentally for your patients. So we need to honor patients' cultures. It helps open up that patient therapeutic relationship that we have, and it instills hope for recovery and rehabilitation. That person feels connected with you if they know that you're going to help them with their cultural issues, if you know they understand you. That's like going from Eastern Kentucky to New York and going to the hospital, and there you are, you're like a fish out of water. But if you can find somebody to connect to, somebody that understands, hey, I'm from this Bible Belt culture in the middle of Eastern Kentucky, where we're driven by family, we're driven by relationships, we're driven by connectedness. We have these wonderful support systems. You can call your neighbors, uncles, brothers, sisters, child, and they'll come to you. New York doesn't have that. They're normally very independent, alone people. So if you can find that one person that you connect to, you're going to feel better. Same thing goes here. You have to find that connection with your patient. Which leads me into connectedness. Support from other members of a group living with mental illness. Non-judgmental atmosphere, opportunity to hear one's perspective. You've got to find that connectedness with that patient. You've got to be able to find some way for that patient to be connected to you. Upon discharge, you want them connected with a support group or family member or somebody that has a non-judgmental atmosphere that will provide care for this patient culturally and spiritually. Able to hear that person's interactions. Meaning in the experience. Suffering may lead people into a spiritual domain. Now, when I'm talking about spirituality of care, I don't dive into it much in this class, because you had that in 101. Basically, we only had one phrase, spirituality and nursing practice. That's on page 102. You can read that, but basically you need to be attentive to the patient's spiritual concerns, just as you're attentive to them with their cultural concerns. You need to be able to understand that they have different needs as we do, and we have to address those needs. Attentive to the concerns, accountability, what's good for the patient, sensitivity to their needs, and being active in that care, and documenting that continuity of care, documenting that we address those spirituality needs. That's it for lesson plan 2. I hope everything is going well. I hope nobody is snowed in too bad. I am also going to try to record lesson plan 3. I'll be posting that up a little later on, in case we don't have lecture the rest of the week or next week, because it sounds like we got some nasty snow coming in. Also, if you're having trouble with My Nursing Lab, please feel free to email me. I'm checking my email periodically. Remember, the pre-tests are not required. They are there. I opened them up for you to do, for your knowledge, and evidently it's a prerequisite in the program that I cannot change, so you might have to do them in order to proceed through the program, and I'm talking with Pearson about trying to get that changed. But for the future, for right now and into the future, just continue to do those. Again, those are not required, but they will, and they will not be graded, but they will be opened up, so you can do those and move on through the program. Any other problems, let me know. I hope everybody has a good Wednesday, and we will chat later.